So I'm sure all of you are tired now. Your brain's probably saturated. And I know Anne picked me for the last talk because she knew I would keep you all awake. Yeah, and I'm wearing red. That's right. You're all going to be awake. So I'm going to talk about CF. It is an interest of mine. And I can't stress what Dr. Faruda said earlier about really in CF clinic. I actually see kids in CF clinic with the pulmonary docs and the dietitian. And having access to a dietitian in CF is kind of critical because the two of you together can really make a difference. And so when I go to see a kid, the dietitian comes in with me to the room and we do the visit together. And then when I'm examining the kid, she'll do the dietary history and ask all the questions. And then since we worked together for so long, we kind of come up with a common plan and the patient leaves with a common plan. And that's been very, very helpful. So what are our goals for kids with CF and nutrition? Again, we know a goal is normal growth, which really depends on their GI function, including pancreatic and liver function, lung function, genetic potential, and energy and nutrient intake. And this is the theme of what you've been hearing today. So someone said, why did you put this old slide up? And I really want to illustrate the importance of a high-calorie diet, or we would say a balanced diet, a high-calorie balanced diet. So in the old days, Boston had a big group of CF kids, and Toronto had a big group of CF kids. And then they found that the kids in Toronto did much better, and that was because they were on a high-calorie diet, and they didn't restrict fat. So they put the kids on a high-fat diet. They didn't care what the stools looked like, whereas in Boston, they restricted the diet so as to manage the stool output. And so they found, they did this comparison of survival growth and pulmonary function between these two CF centers, and they found good weight and height percentiles and improved survival linked to good nutritional status. And since then, care in the US changed, and everyone was put on a high-calorie, high-fat diet initially, and now I think it's more of a high-calorie balanced diet. And I don't know if you've seen this, but I think the trend is going away from using animal fat to increase calories and using more of vegetable fat. But I think the bottom line is get the calories in the best way possible. So I show you this report only to say that survival is improving. And if you look at the cohorts of patients going from 1985 to more recently, the survival is improving. So care in CF is improving. I think nutritional care is improving as well, but we can't take all the credit for it because there improves improvement in antibiotic therapy, pulmonary therapies, etc. So what's the pathogenesis of nutritional abnormalities in CF? And it's kind of like Praveen's slide about failure to thrive. We look at losses, which may be related to malabsorption, reflux, CF-related diabetes, thank you. And then protein loss in sputum. If you have someone with a lot of pulmonary disease who's expectorating a lot, don't underestimate protein loss. And we've all heard about how important protein is to our patients. Energy intake, this is if they are on iatrogenic fat restrictions, for various things, this might happen: esophagitis, anorexia, feeding disorders, and depression, especially in older CF patients. And energy needs may be increased not just from malabsorption, but also could be a primary defect at the genetic level, suggesting why these kids may have higher energy needs. So this is a list of all the nutritional abnormalities, and I'll try to go over most of them, but the time doesn't permit a detailed description. So we can see malnutrition, growth failure, protein deficiency seen mainly in infants, and that's the child that we don't see too much now, but when I was a first-year fellow, we would see these kids coming in with hyperproteinemia, edema, because they weren't diagnosed early. But now with newborn screening, which is in all the states in the US, these kids are identified sooner, and so they get treated sooner, so we really shouldn't be seeing that. Micronutrient deficiencies, delayed puberty, and then bone disease. So I took out a lot of slides, but the bottom line I put this here to tell you is that CF care is improving, and like we see an improvement in BMI percentile. So if you look at 1990, the BMI percentile the goal is over here. The percentile, now we're doing a better job with it, and this is similar for height percentiles as well as weight percentiles. And I will talk The next slide will show what the CF Foundation recommends. So there was a consensus conference looking at what the optimal growth pattern should be for kids with CF. And for kids less than 2, it's weight for length percentile at the 50th percentile. And for kids over 2, it's really BMI percentile at the 50th percentile. And I think that this parameter is followed or attempted to be followed in all centers. And if any of you are involved with CF care, you'd know that the CF, all these centers are affiliated with the CF Foundation, and data is collected on a yearly basis. And CF centers get this report of what all kids with CF are doing nationwide, and then where your center stands with respect to pulmonary function, weight, BMI percentile, tube fees, CFRD, pulmonary function, all those things. And so people get this report card of what they're doing, and so everyone knows where you stand relative. So there's this big push to get BMIs up to the 50th percentile with good success. However, on the other side is there's some people who are not born to be at the 50th percentile, and you have to look at what their parents are. So if you have tall, slim parents, your BMI would be okay, but I think you have to take into account what your genetic potential is. So this slide looks at FEV1 and BMI, and the data shows that pulmonary function, nutrition status are highly correlated, and that some centers were achieving the goal. And what they found was at a percentile of 50, you had optimal lung function. And this is a scatter plot of where the centers are. And if you can see FEV1 of 100% predicted and a BMI percentile, there are some centers who are up there. There are a lot down here, and there are some here. So the goal is to move everyone up there, and this shift is slowly happening. So what do we know about energy needs and CF? We know that height and weight is linked to survival. That's very clear. We know that there's an association, as I showed you from the previous slide, about BMI percentile and FEV1. And we all know that optimal energy is important for care, and that's from just all the GI and nutrition we do. The individual variables in energy intake and energy needs are really pulmonary exacerbations, where your energy needs will go up, maldigestion, malabsorption, and that's not just pancreatic function, it's also small bowel damage, from bacterial overgrowth or from celiac, and liver disease. I can't emphasize that you really need to look at all those three things, the gut, the pancreas, and the liver, because we had a patient who had a liver transplant, and her pancreatic enzyme dose dropped to 25% it was pre-transplant, just because the liver was working better and she didn't need as many enzymes. So you really need to look at everything that's going on with the patient. Pulmonary function, and in research studies, sorry, I keep hitting the wrong button. Fat-free mass, gender, pubertal status, mutations were all related. It seems as though the daily caloric requirements vary from 110 to 200%, depending on what study you're looking at and depending on the age. And the bottom line is, no matter what the number is, you need to increase it to achieve the growth that you're looking for. The CF also, that's a sign for me to end. But there was a consensus meeting of some few years ago where they had all these elaborate equations, and the most recent consensus said that you really need, those are just starting points, and you really need to look at what the patient's doing. And then use gains in height, weight, height velocity, and fat stores to assess adequacy. Looking at protein needs in CF, there's limited information. We know that protein intake correlates well with caloric intake. And the studies on protein catabolism and deposition showed variable results. And supplementation studies also showed conflicting results. So I think if we have our patients on what we consider an adequate diet, if they have short bowel syndrome, they might need more protein. But if we balance that, most kids with CF do not show any evidence of protein deficiency or protein losses. Vitamin A, I think some of this we already have talked about, but in CF, we know that serum retinol is decreased in acute inflammatory states when they have a pulmonary exacerbation, et cetera, and it is not associated with disease severity. And there's been no trial showing benefits of vitamin A supplementation. In 1993, CF-specific multivitamins were introduced that contain vitamin A, and sometimes those vitamins have been used for kids with short bowel with varying results. And we have seen elevated retinol levels in children, adolescents, and young adults. And to monitor toxicity, we usually measure serum retinol esters. Vitamin E is very important for normal development, cell membrane stability. Deficiency is seen with any patient with fat malabsorption. CF is one of those groups. We know that oxidative stress, which occurs in patients with CF and diets high in PUFA, may increase needs. And there was a lot of vitamin E deficiency seen in patients with CF before the development of CF-specific vitamins. So nowadays, you really shouldn't see vitamin deficiency. And with the dietitians and the CF teams really monitoring vitamin levels on an annual basis, we don't see very much of this anymore. We might see it in kids with short bowel syndrome, and that's about it. Low levels have been seen in infants at diagnosis and during childhood, and there's varying results on the effect of vitamin E and lung function, and so we usually check vitamin E levels and adjust their doses. Vitamin D, we've heard about this already, and deficiency is common in infants at diagnosis, children, and young adults, and that probably is reflective of what we see in the general population at large. The factors, I've listed the factors over here, which aren't specific to CF, except that they are on a lot of glucocorticoids and antibiotics. There are new AAP guidelines, IOM guidelines, CF and Endocrine Society guidelines, and we can talk about this in the question and answer session, about what level to use, what doses to use. And the CF, there was a recent consensus conference where it lays out very specifically what they would like patients with CF to do. And they define deficiency as less than 30 nanograms or 79 nanomoles per liter, which is a little different from the IOM report. And the treatment is vitamin D supplements, and again, the report lays out what the better supplement to use is, what doses to use, etc. And the references there. So with vitamin K, these are the factors I listed, which would be responsible for vitamin K status in patients with CF. So maldigestion, malabsorption, bile salt deficiency, liver disease, bowel resection. Deficiency we know that vitamin K is important for bone health, and so it is associated with low bone mass. Supplementation, we know, improves markers of bone formation. We used to use prothrombin times, but I think now more people are using, as part of the annual studies, PIVKA2 levels, which is a better marker of vitamin K sufficiency, and there are no instances of toxicity in patients with CF. So water-soluble vitamins have been studied in patients with CF. The multivitamins contain water-soluble, the CF-specific multivitamins contain water-soluble vitamins. Riboflavin deficiency has been seen. Vitamin C levels do decrease with age, and this may be related to oxidative stress, because as you get older, your lung disease deteriorates, you have more pulmonary exacerbations, etc. And when there was one small study which looked at folic acid and B12 supplements showing there was improved inflammatory responses, but it's not like we go and supplement everyone with this. So sodium, we all know the importance of sodium in patients with CF because there's excessive salt loss to the skin. This may be influenced by genotype, depending on what mutation you have. Human milk and infant formula does not contain enough salt, and so the recommendation is for infants to supplement them with 1/8 of a teaspoon till 6 months, and then it's increased to a 1/4 teaspoon, and then older patients are put on a high salt diet. So they're told to add more salt to their diet or eat salty foods. And if they're active in warm environments, they're recommended to add salt to their sports drinks, and sometimes we'll do this to tube feeds as well at night. And salt depletion can cause anorexia, failure to thrive, metabolic acidosis, alkalosis with hyperelectrolytemia. Trace elements, we've talked about zinc, and I would go ahead and reinforce what Praveen said about zinc. A CF Foundation, as I said earlier in the day, actually recommended empiric zinc supplementation if you think someone may be zinc deficient. And what we found is in giving these patients zinc supplements, some of them, when we take them off, they slow down their appetite, their weight gain slows down, and some of them have been on zinc for longer. But not that I know, no one's done zinc balance studies in these patients or more sophisticated measures of zinc status. And prior to diagnosis, there is evidence of zinc and malabsorption, zinc loss and malabsorption. So trace elements, I think this is something that was not recognized initially, and as kids are getting older, we're recognizing iron deficiencies in patients with CF. So anemia is frequently seen. There is an association between poor lung function and vitamin deficiencies. The incidence is 33% in children and 74% in older patients. And I said we're recognizing this now that we have more adolescent and young adults. It could either be a true iron deficiency or an anemia of chronic disease. And so it's important to distinguish that, especially if the patient's having recurrent pulmonary exacerbations. Deficiency is related to decreased intake, increased losses in sputum or in the GI tract, and the severity of suppurative lung disease. Iron deficiency is not related to enzyme therapy, and that was a thought initially. And I think what was interesting for me is the link between Pseudomonas and iron, because Pseudomonas acquires iron from proteins in the host airway. It secretes siderospheres to acquire iron, produce inflammatory cytokines, and then results in anemia of chronic disease. So the mechanism is a little complex. Fatty acids, this is a hot topic in CF. I think at the, I want to say 1998 CF meeting, everyone thought that if we normalized fatty acid status that we would be able to improve a lot of the things, and that hasn't really panned out. But deficiency can be seen at diagnosis, and some of the kids may only have a biochemical deficiency, but these are some of the things we might see. Causes are fat malabsorption and abnormal membrane release and metabolism. And while we know more about this, it seems like supplementation so far hasn't translated into improved clinical outcomes. Improved levels, yes, but not improved clinical outcomes. So it seems like EFAD is associated with ceramide deficiency, and ceramide is very important for the cell membrane. CF genotype and pancreatic status is also associated. We know that serum linoleic acid status is associated with growth in pulmonary status, and abnormalities increase with the presence of age and CF liver disease. And clinically, we do see patients with abnormal linoleic acid levels and decreased DHA. But the treatment hasn't really resulted in any effects with respect to clinical outcomes, so it's not a widespread recommendation. What we have done, though, and this is again clinical, so I'm happy to share anecdotal. In kids who have essential fatty acid deficiency, especially the older kids, sometimes when they come in-house, we might give them some intravenous fat when they're in for a week or so, just to boost their levels up. Because some of these teenagers who are getting repeated lung disease, they often don't want to increase the fat in their diet because they don't want to get fat, but they have essential fatty acid deficiency. And sometimes I feel they regulate their body weight based on what they want to be by adjusting their enzyme intake. So when they're in-house, it becomes a way just to boost their essential fatty acid levels and try and normalize them. And I think Brigitte Strandvik in Sweden has done this, and this is something that we borrowed from her just from meeting her at conferences. So bone health is a very big topic, and I've condensed it into one slide, but we do see decreased bone density, fractures, and kyphosis earlier than in healthy controls. There is an increased incidence of osteoporosis and fractures, and this increases with age. It's more prevalent in adults and those with end-stage lung disease. And this is especially problematic because some of these patients end up getting lung transplants, and it's hard to give them good physical therapy because their bones are so fragile. And we actually had a patient who had a lot of fractures, and that did affect his immediate post-op period. The risk factors are inflammatory cytokines, D deficiency, calcium, steroid use, small body size, low weight for height, decreased activity, delayed puberty, and if they have comorbidities, as well as a family history of osteoporosis. The CF Foundation does recommend that all kids have a DEXA scan, a baseline DEXA scan at 8 years, and then you repeat that afterwards, depending whether they have risk factors or not. You might do one sooner, depending on what's going on. So treatment is optimize calcium, vitamin D and K, nutritional status, increase physical activity, decrease steroid use if possible, treat any hormone deficiencies, because the importance of the pubertal hormones and pubertal delay cannot be underemphasized. And then bisphosphonate medications have been used. So moving on to the nutritional management, now that we have this whole background, what you should know is that patients have different needs at different ages, and you really need to fine-tune or modify your treatment based on their age. So the nutritional assessment is what I described earlier in the day. Nutrition education, dietary counseling, so your dietitian is very important. We will give them pancreatic enzyme replacement therapy if they're pancreatic insufficient. And then we supplement micronutrients, and then the actual diet therapy is oral, tube feeds if they need, and sometimes parental nutrition. But the number of kids with CF who get parental nutrition is very, very small. So it is not a preferred modality. I think the oral diet is what people would prefer and try first before we go with tube feeds. So anticipatory guidance. So what do you do at the different stages? So breast milk is best. If they can't breastfeed, then formula. We advise them as to solids. And then sodium supplementation. In toddlers and preschool children, again, is caloric intake. How do we boost their caloric intake? We look at feeding behaviors because, again, we don't want the kind of kid Praveen talked about where they're force-fed. The parents are so focused on getting their weight for length up, getting them to gain weight, and then everyone's crazy at home and the kid says, I'm not going to eat. So we really need to impact on feeding behavior, and then the importance of whole milk. A lot of pediatricians now are saying go down to 2%, 1%. People know what the cholesterol levels are. And so I think in someone who's doing well, 2% or 1% is fine, but if they're not, then you really want to give them whole milk. In school age, it's important to stress autonomy because now these children have to start making choices. And, we encourage CF kids to assume their care at 18. They're going away to college, etc. So you want to start training them from a young period. And school-age kids, they do have autonomy. They can decide whether they're going to take their enzymes in school, whether they're going to eat all the snacks that get put in their lunchbox. And so this is important. And I would say you're not really working just with the kid, but you're working with the family as well. And education. And in adolescence, this is a very high-risk period because these patients can get diabetes, liver disease, they have more infections, they have pubertal delay, they're going through puberty, so you don't want that to slow down. Increased physical activity, they're involved in sports, they have adolescent behavior, and now I guess there's tween behavior, not just teen behavior. And eating disorders is very prevalent at this time. So this is, again, what the CF Foundation recommends in terms of routine CF care. And as you can see at diagnosis, it's recommended that everyone have the anthros done. They recommend, arm anthropometry as well. I'm not sure that's done very often. Looking at parental height, so you plot that so you know initially what percentile or what range on the growth chart you want them to be. And then they get their anthros done every 3 months, and then these selected measures. And then annually, they get all these things done. And this is what the dietitians will go through when they see them on an annual basis. And I think the recommendation is that every patient see a dietitian at least once a year. So I put this slide because this is what I found from clinical experience. I should probably do a study and put some percentages behind these. But when you see a patient who's not eating well with CF, these are some of the things I've come across. Reflux, gastroparesis, bacterial overgrowth, sometimes if they're on medications. Flagella is just one of the ones I put there. Poor eating habits, similar to what Praveen described, lack of mealtime structure, behavioral problems. ADHD, they're just floating around, they can't sit down, they're hyperactive. Eating disorders in the older children, depression, lung disease, and I can't stress this. I had a patient who they put on tube feeds, was still not gaining weight. They brought the kid in for a tune-up, and all of a sudden, all those extra calories that we were pouring in suddenly made a difference. So you really have to look at the inflammation in their lungs as well, and sinus disease, sinusitis, and then zinc deficiency. So what do we do when poor growth is identified in patients with CF? Similar to what we do in other diseases, we see them more often. We include complete medical, behavioral, nutrition assessment, education interventions. We do a diet analysis. I mentioned this earlier. And what's important is, where they're eating, when are they eating, who are they eating with, what foods are they eating, and how much. And you can do a 3-day diet record. RD is important. And really, we talked about our aim is to achieve the optimal weight for length and BMI percentile. So this is an algorithm, which is a useful one. So you have a patient, weight loss, lack of weight gain, lung disease, sinus disease active? If it's yes, you treat. If there's no weight gain, then you consider these conditions. Then you go down to, is there signs of malabsorption or not? If there are signs of malabsorption, then you look at, are they adhering to the regimen you've prescribed? Is the enzyme dose ineffective or low? Are they drinking a lot of juice, high-calorie beverages, empty calories? And then we would add an H2 blocker, a PPI, to improve fat absorption, and then reassess. And then you counsel them, you correct the problem, the enzyme's an issue, and then you have a dietitian work with them. If there's no malabsorption, you still have them work with the dietitian. Look at feeding behavior, look at psychosocial economic evaluation and intervention, look for CF-related diabetes, and then look for these other conditions as well, and then consider use of enteral feedings. Lab monitoring, this is what's recommended at diagnosis. Again, we look at all these things, and then on an annual basis as well. Essential fatty acid levels are, or the profile is done in kids who are at risk, and then once it's abnormal, you'll follow them, you'll monitor them. So what's the behavioral evaluation for patients with CF with poor growth? You assess early, you check for ineffective feeding behaviors and parenting strategies. Adolescents with very poor body weight, you'll check for an eating disorder, check if they're skipping their enzymes. So the rule is, there were Corkin's rules, right? So I guess this is a Maria rule. If they say they're missing enzymes once a week, you know they're missing it more than once a week. But you want to know the truth. So they feel comfortable enough to tell you, then you can assume, yeah, it's more than that. And then encourage being open but discreet about CF. So pancreatic enzyme therapy. I can't tell you how many calls I get from people from clinic, GI clinic. How do you dose the enzymes? So I want you all to leave from here knowing exactly how to dose enzymes. So there are enteric-coated capsules with microspheres. They vary in pH and source of lipase. You open for children who cannot swallow the capsules, you open the capsule in applesauce and you develop a routine. Now, it could be other foods other than applesauce. It has to be an acidic pH. So I've had patients mix it with ketchup, and I say, well, what's the pH of ketchup? And it is actually acidic. So you really want consistency. You don't want them to pick different foods. You want to check in infants for mouth ulcers. You don't want them to crush the beads or add them to the bottle. Enzymes should be stored in a cool, dry place, especially if they're going to the beach or in the hot climates, because that'll inactivate the enzymes. An adequate number is required, and so it's not one size fit all. I mean, you could say, yes, with meals you take so many, with snacks you take so many, but if their snacks is really carb with no fat or not much protein, they probably require less. And we focus nowadays on the total daily dose of enzymes. So you really at every visit have to add up the number of enzymes they're getting throughout the day to make sure you're under that 10,000 lipase units per kilo per day limit. You want them to take it with all foods and beverages except for simple sugars, carry enzymes with them all the time. They're best if swallowed, check them for freshness. Generic enzymes are a no-no. And we split the enzymes if the meal is longer than 20 to 30 minutes. They were taken off, not taken off the market, but there was in 2000 and, gosh, when you get old, the dates just blur. But the manufacturers of enzymes had to actually go ahead and do studies. And so for a time, there was only one enzyme product on the market. I think Creon was the first one. And now, as of last month, there are 5 on the market. So we have better choice. But for some time, we only had 1 or 2 products that we could choose from. So in 1995, there was again a consensus conference where they talked about the dose, and they've kind of made up these doses, but this is what we follow. It's 2,000 to 4,000 lipase units per 120 mLs of formula per breastfeeding. Children less than 4 years, that's the dose they use. Children more than 4 years, that's the dose they use. And there's no good explanation why adolescents require such a low dose, but you could have an adolescent on 500 lipase units per kilo per meal, where you have a toddler who's on 2,200 lipase units per kilo per meal. And there was a study using a new formulation which was made from actually algae. And they actually did a fixed dose study where they gave a fixed dose of enzymes without varying it and a very low dose relative to these guidelines. And they looked at CF coefficient of nitrogen absorptions and fat absorption, and they found pretty good results. So kids may not need as many enzymes as we give them. The other way is to do a half standard dose with snacks. And then to look if you're actually doing a diet record and you can figure out how many lipase units or how many grams of fat there are in the snacks, you can actually dose your enzyme based on lipase units per gram of fat. But there's a very big spread there. So if you have a patient whom you think is on an adequate dose of enzymes and they're not responding, what do you think of? So the symptoms they might have might be any of these. And the causes could be any of these. So juice intake, grazing, fast food, missing their enzymes. They're outdated. They're keeping them in the glove compartment when they're going to the beach. They've gone to Disney and they had them in their backpack. Acid intestinal environment. We'll talk about this a little bit. Actually, we can talk about it now. The enzymes are designed to be released at a certain pH. And so kids with CF have high gastric, high duodenal pH because there's not enough pancreatic juice, which is alkaline, to raise the pH. And so that's the reason for giving patients acid blockade medications. So if the acid in the intestinal environment is acid. And then GI conditions like lactose intolerance, etc., will give you the above symptoms, and you might say, oh, it's because of they need a higher enzyme dose, but they really have to treat the other conditions. So this is an old study, but I use it because it's from Peter Dury, who's the king of pancreatic disease, and really probably one of the, has made a lot of contributions to the field of CF and pancreatic disease. But he looked at cimetidine and bicarb on pancreatic enzyme replacement therapy, which is PERT, and they actually saw improved fat and nitrogen balance with cimetidine or bicarb, but no additive effect when both were used at the same time. And then more recently, there's been a study looking at PPIs, and again, they saw that fat malabsorption decreased from 13% to 6%. Appetite stimulants. So these appetite stimulants have been used in patients with CF. They should not be routinely used. I would say Periactin of them is the mildest and the one that we would try if we need to. People have used Megaze for short periods of time, and it increases appetite, weight, but it's not sustained, and then there are the adverse effects of adrenal suppression, etc. Insulin can be used, again, probably more in conjunction with CF-related diabetes, and growth hormone also can be used, but I would say these are probably side effects, the appetite stimulant effect, rather than primary therapies. Tube feeds in CF. So this is another thing, and I think we're going to have an enteral nutrition slide set, so we will have more focused, CF will be a focus in it. But in general, we like to give, similar to other diseases, 30 to 50% of their goal calories overnight, and we do it overnight to allow normal daytime eating patterns. And as Dr. Corkin said, breakfast never eaten well, but they usually pick up by lunch and dinner, and then they get this overnight. And then once they gain weight, especially the older kids, and they feel better, they have more energy, they're more active, and then we slowly wean the calories. And there are many teenagers who needed tube feeds when they were infants and toddlers and have come off them. One, because they didn't need them. Two, because they didn't want the tube anymore. But they have done well. It's not like a lifelong commitment. So in infants, we usually aim for 120 to 150 calories. Again, looking at catch-up, lung growth, long-term growth. We titrate calories based on weight gain, their fat stores, and growth. We usually use standard formulas, and they're very well tolerated. We might use very low-fat elemental formulas if they're intubated, if they're on continuous feeds, and then you don't have to put enzymes through the tube. You can use calorically dense formulas. And I think we've not had as much success with this in children, but when they go to our adult center, when they transition, they often will use a 2-calorie per ounce formula at night, and they get away with it. But in children, we've had a lot of fat malabsorption and bloating and feeding intolerance. So I think we've worked better with a 1-cal, or if we do a 1.5, something that's peptide-based. And then in a patient who has excessive anorexia, bloating, and nausea, then a semi-elemental formula may be useful. So I've tended to individualize formulas a little bit with patients based on what's going on. So if they have short bowel, high fat, something with MCT, low simple sugars, Malabsorption, if they're having ongoing malabsorption symptoms, something that's partially digested. If they have diabetes, a CFRD, we use low simple sugars, advanced lung disease, high fat, severe reflux, more peptide-based to improve gastric emptying. And if they have concomitant food allergies, and we have 2 kids with EOE, then amino acid-based. So this is another question that you all should remember. How do you give enzymes when you're on tube feeds? Okay, so you usually take the dinner dose at the start with all feeds except for very low-fat elemental formulas. And if the kid does okay with this, they're gaining weight, they're not symptomatic, that's all you need to do. If they're not doing well, then you may need to give doses at the end of feeds. And if they're still not doing well, then you can give a dose in the middle of the night. So that's a pain to wake up in the middle of the night and take enzymes. So that's why you start initially, then add the at the end dose, and then you can add the middle dose. It's important to check blood sugars 2 to 3 hours into the feeds, because sometimes you're giving them a big sugar load, and these patients are at risk for CFRD, and this you may be precipitating some high blood sugars. And the recommendation is if your blood sugar is high, you may need insulin, and especially if the patient's not gaining weight, is ill on steroids. In the NICU, so if you have a kid with meconium ileus who's had surgery, who starts on tube feeds because they can't take oral feeds, or, then what we recommend is when their formula intake is about 60 mLs Q3 hours. Jacob wouldn't be happy with that, right? We're supposed to do all mLs and not cc's. But 3,000 lipase units, again, in applesauce. And this happened, I think, over the Christmas holiday. I was on vacation. I get this email. This kid's not going to take applesauce. And believe it or not, the NICU nurses can get them to take some beads in applesauce. And it's just a small amount. And what did Mark say? If you put something in the back of the throat, they'll swallow it. So there's the Corkins rule again. And what's also important is if you're on continuous feeds, then you can use the same dose, but every 3 hours, every 4 hours. There are some recipes from the formula, from the manufacturers of the enzymes, where you can blend it, where you can dissolve it with some bicarb, but I would suggest you work with your pharmacist on that, or I can give you recipes once I get back, because I have them all written down, but I didn't put them in the talk. And then watch for skin breakdown at the ostomy and anus if the kids have short bowel, because if their transit is rapid, then you might see the enzymes coming out and some irritation. And then clean the mouth after feeds to prevent oral ulcers. So here's our case study. 5-month-old with weight loss diarrhea, 6 to 8 stools a day. They're loose, foul smelling, so you're thinking malabsorption, fat malabsorption, was diagnosed by newborn screen and was referred to a local CF center. Father changed jobs. They said they were giving all the prescribed therapies. They said she's an excellent eater, very hungry. Goes back to what Praveen said about pancreatic insufficiency. Happy, some mild developmental delay. Was getting about 48 ounces of standard infant formula, so decent amount, and 2 ounces of rice cereal mixed with water twice a day. Medication, standard infant vitamins, was on enzyme therapy, was getting it 4 times a day. Mother was pouring beads down her throat, followed by 1 ounce of water in her bottle to wash it down. So you examine her. She's less than the 5th, head circumference on the 25th, so there's some sparing there. She has abdominal distension, hepatomegaly, and wasting. So which of the following is false? Salt supplementation, enzyme therapy should be given before all meals and bottles. The enzyme therapy is correct. Weight for length should be at or above the 50th percentile. I'm following the Godet rule. If we're going to pimp you, we've got to use the accept. All right, that's the correct answer. Okay, good. You're all paying attention. Oh, should I have gone back? No. It's like Harry Potter, actually, these moving things. You know, it's like the newspaper, right, with all the people moving. Okay, so I wanted to just talk a little bit about the nutrition guidelines. The CF Foundation came out with guidelines in 2009 for the management of infants, and they just talk about human milk formula, breast milk or standard infant formula. You don't really need hydrolyzed protein formulas, which people were doing before, and they're more expensive. dense formula feeds if there's weight loss and inadequate weight gain. Otherwise, standard infant formula should be enough. Encourage positive feeding behaviors, and if there are growth deficits, then follow these kids very closely. Start multivitamins with appropriate amount for CF shortly after diagnosis. Check fat-soluble vitamins 2 months later. So you're not going to do it at diagnosis because they're pretty much newborns. And then you supplement them. So again, we're cutting down on lab tests, okay? And then frequently, if the labs are abnormal, you can trial zinc if they're not growing well, salt, we talked about this, and then fluoride. They actually went out and made fluoride recommendations. So here's the next question. Vitamin supplementations in patients with CF consists of all of the following except. Take a guess. So actually, the waters, we have 6, 10. So vitamin supplementation has water-soluble forms, the CF-specific enzymes are best given with meals. Vitamins are best given with meals and PERT. They contain higher doses of fat-soluble vitamins and zinc. And the RDA is for the water-soluble vitamins, but they have more fat-soluble vitamins, okay? So the next slide shows a comparison. And if you can see, CF-specific vitamins have more A, E, and D. They have vitamin K compared to standard. That's the infant formulation, and the older kid formulation is much more than the standard. They contain zinc, biotin, pantothenic acid. I have no idea why they put those in. And they have B12, C, and thiamine as well, much more. Actually, they have them there as opposed to standard multivitamins, but there's no folate in either of them. And actually, the kids I've checked folate levels on have all been high, probably related to bacterial overgrowth. So enzymes were provided before bottles and cereals. Salt was added to we're going to stick with this girl for a long time, by the way. Salt was added to her diet. CF-specific multivitamin was prescribed. Her cereal was mixed with formula for increased caloric intake. Never do it with water. She came back in 2 weeks. Her weight gain was excellent. Formula intake decreased, but she still gained weight because now she's actually utilizing the calories we were putting into her. Her BMs decreased to 2 to 3 soft pasty stools a day. She had excellent weight gain, linear growth at monthly visits till she was a year of age. After that, we decreased her. I think we followed her pretty closely because with the father changing jobs and the fact that they had been diagnosed since birth but had still not learned what they'd been told, we just wanted to keep an eye on this girl. And then at annual studies, her labs were okay. Her father got a new job and she was transferred to another CF center. So she returns to a CF center at age 14 because her paternal grandparents lived in the area, so they came back. And she says she's doing very well, she has no problems, she has regular stools. How many times have we been told by our patients, my stools are regular, and when you tease out the details, then you really get the dirt. Pulmonary function tests were 48% predicted, so that's not good. So 80 to 100% is normal. Her weight was less than the 5th percentile, and you had actually got her on the growth chart doing well before she left. Height was 10 to 25th, BMI was 5th. She had bilateral crackles, and she was admitted straight away for pulmonary and nutritional management. So in the hospital, the nurses observed that she had 3 to 4 foul-smelling loose stools a day, had a lot of gas, and really wasn't eating. So which of the following would you not do? Would you check fat-soluble vitamins and zinc levels? Would you check a celiac panel, screen her for CFRD? Would you do breath tests looking for lactose intolerance and bacterial overgrowth? Would you start an appetite stimulant, and if not successful, then nasogastric tube feeds? Would you optimize enzyme therapy? Okay, so we're 15, that's pretty good. So people have said that there's an increased incidence of celiac disease in patients with CF. So checking a celiac panel is not an unreasonable thing to do. Checking of a CF-related diabetes is not unreasonable because she's 15. She should have actually had an oral glucose tolerance test when she was 8 because that's a CF Foundation recommendation. Optimizing enzyme therapy is a good idea, and checking her vitamin levels and zinc, doing all that is also a good idea. Breath tests to look for lactose intolerance and bacterial overgrowth. So this is a little bit of a tricky thing. So you could do them, or you could empirically get a history to see if you suspected it, and you could empirically treat her. But the one thing I wanted to stress is we don't want to start her on an appetite stimulant. We want to do everything else first and then start an appetite stimulant. Because you really want to know what's wrong before you start doing those kind of interventions. So her fat-soluble vitamins were all low. She was zinc deficient. Her baseline breath hydrogen level was high. Breath test couldn't be performed. So she was given a course of metronidazole for 10 days. Celiac panel was negative. Her glucose levels were normal. Her enzymes were optimized. Vitamin zinc was given to her. CF dietitian reviews with her a high-calorie diet, goes over enzymes with her, tells her how to adjust her enzymes based on the fat content of her meals. She started some oral supplements, like we all talked about, and she gains weight. First, her lungs are better, so her energy needs have gone down. She's taking her enzymes better. She's feeling better. FEV1 improves, and she's now 80% predicted. On subsequent visits, so she's doing well, but then you notice that she starts having some declining lung function. She can't keep up with the oral supplements, and her BMI drops, and they say, can you see her again? Can you help us out? So what would you not do next? So 24-hour diet recall, review PERT use and start a PPI, look for symptoms and signs of malabsorption, psychosocial history and assess for eating disorder and depression, start her an appetite stimulant. Obviously, less is more, so you don't want to spend more money because nowadays everything is capitated and parents having to pay more out of pocket for medications, tests, etc. Excellent. All right, we're going to move along. So her enzymes are good, the dose is good, she's taking it appropriately. We don't think she has depression or eating disorder. You bring up tube feeds, and she says, I don't know, I'm not sure. Maybe can I talk with someone else? And this is a very important thing that for teenagers who have to make the decision as opposed to an infant or a toddler where the parent makes a decision, they need to buy into it because you could put a tube in, but they'll not use it, and they'll give their parents a very hard time using it. So you really need, and so she says, can I talk to someone else who's done it? And then after much discussion, she agrees to the tube feeds. So regarding her tube feeds, which of the following is true? You're going to get an REE and a 72-hour fecal fat to accurately determine calorie needs. You're going to give her a half dose of enzymes in the middle and the end of her feeds. You're going to give her a PPI to be given when feeds start, at the beginning of her feeds to optimize enzyme therapy. And you're going to start her feeds at 25% goal and advance every night as tolerated. Excellent. So nutrition plays an important role in the care of the patient with CF. Growth assessment should be done at every visit. The goal is BMI at the 50th percentile or weight for length at the 50th or above percentile. Annual monitoring should be important part of management. Enzyme therapy should be reviewed at every visit for the total daily dose and when the patients aren't growing optimally. I didn't talk about this because I had to really condense my slides. But doses higher than 10,000 lipase units per kilo per day were associated with fibrosing colonopathy. And that's why we try to keep the dose within that level. And then the CF dietitian should evaluate the patient quarterly or more often if there's growth failure, but at a minimum once a year.